So thank you very much again, Dr. Sriram, Dr. Hassan, and thank you for members in the audience for hanging in there and listening to us. Thank you for your attention. I'll be speaking on pediatric cervical spine trauma, but before I speak about pediatric cervical, not pediatric, sorry, I'm speaking on cervical spine trauma, adults and pediatric. Sorry, that's my fallback, so I keep going back to pediatrics. But when they were showing the video of radiology, what was old and new, I suddenly remembered this slide from my hospital history books and I thought I'd put it up. So this is a slide from 1896 from the Hospital for Sick Children. Remember that in 1895 X-rays were discovered. 1 year later we had an X-ray machine and there is an unknown person taking an X-ray of a foot of a child for suspected fracture in 1896. This is a documented, proven photograph from the history books of the Hospital for Sick Children. And I'm very proud to be working in that hospital, not only working, but leading a very good department where people like Erica and many other experts work. And we are a good family together. We really enjoy going to work. In fact, when there is a day off, you sort of worry about not going to work because you just enjoy going to work. It's a nice place to work in. It's a pleasure and an honor. So I'm going to speak on cervical spine injury. I'm a neuroradiologist by training, adult and pediatric, and I will show you both sides of the spectrum. Usually when I give my lectures and even when I speak to people, I like to tell stories. So this is one of my other stories over here. So these are 3 stories which I'm showing you in the beginning before I launch into my talk. These are 3 X-rays where I made significant mistakes and I want to see if you guys can pick it up. Some of them are easily detectable and I just made stupid mistakes. Some of them are very difficult. This was the first one. Actually, somebody who is known to Dr. David Manson, who's one of our general pediatric radiologists, a very, very skilled radiologist. And he brought me this X-ray saying, do you think there's something wrong? And I said, no, it's okay. We did a CT and even then I thought it was okay. I thought that this wedge thing was just a normal variant in a 9-year-old. And this is actually a friend of mine who's a radiologist and he's a divisional interventional radiology chief in USA. He had a car rollover and he bought me his own lateral X-ray and he showed it to me. Do you see anything? I'm getting some neck pain still. And he said, no. I said, it's okay, it's normal. And there's a bias you should not have when you see X-rays of your own friends and families. That's why you should never see it. In this third X-ray, an obtunded patient obviously had a motor vehicle accident with abdominal trauma, and I was asked to clear this X-ray, and I cleared it, but I'll show you the findings in that one later. So you guys think about it, and we'll get to the answers later. So what are the objectives of my talk? I'll go through some normal anatomy, I'll go through some appropriateness, I'll talk about C-spine trauma.
Just a second. This screen is gone off. Can somebody check this please on our computer?
Okay. Excuse me. So we'll talk about adults and children and we'll talk about some unique situations. So the most important thing in terms of radiography, radiography is a dying art, so those of you who do it very well, be proud of yourself and pass it on to the junior colleagues because people are just forgetting about it. At least I think I'm privileged to have worked in the old world and the new world and know X-rays a little bit better than most other people who are the new generation. So when you look at plain X-rays, the most important thing to look at is the lateral view. And on the lateral view, make sure you look at the axis, the C1 and C2, so the atlas and axis. Look for some specific signs. I'll come to the fat C2 sign, what it means. Look for the atlantoaxial distance over here. In children, the maximum limit is 5 millimeters, and adults it is 3 millimeters. Look for the Bayesian length interval and the Bayesian axial interval. I'll come into more details at a later stage of that. And the prevertebral thickness should be measured at C3, and it should not be more than 3 millimeters. So these are all things that you look at. Coming to the fat C2 sign, this is a very well-described sign for fractures of the body of C2. If you see the anterior margin of C3 and the posterior margin of C3, it should go in parallel with the anterior and posterior margins of the C2 vertebral body. If it becomes fatter, like in this instance, then usually it denotes a fracture through the body of C2 in this particular plane. and that is the fat C2 sign. So it's a good sign to look at. And once you look at all these, your sensitivity of a lateral X-ray alone will go up to 70 to 80% to pick up abnormalities. Then when you look at a lateral spine X-ray, make sure that you look at these basic things: the anterior line, the posterior spinal line, and the spinolaminar line. Many people mistake this as the posterior spinal line. That is not so. This is the posterior line along the posterior margins of the vertebrae, and this is the spinolaminar line. These all should align very well. And now, when you talk of clearing the spine with radiographs, if you look at the American College of Radiology appropriateness criteria, you need a good lateral view which includes C7T1. If you don't get it, do a swimmer's view. You need an AP view, and then you need an open mouth odontoid view. Open mouth odontoid view is, easy to say and tell somebody to do, but often you have a failure, technical failure. You don't see the odontoid very well. In our own experience, when I audited the X-rays in my department, there was a failure to get a good odontoid view in 25 to 30% of cases. So it could be a problem, but if you have a good technologist, then you usually do a good job. So that was about plain radiography. What about other modalities? Now CT is becoming really the mainstay of imaging in cervical spine trauma. So much so that in many adult emergency departments, they don't even do lateral radiography or radiography of the C-spine. They go ahead and do a CT scan straight away. It has a very high sensitivity for fracture and subluxations. You can do CT angiography if you suspect vascular trauma, particularly when you have base of skull or odontoid or occipital fractures. In fact, in the upper spine, you can even pick up epidural hematomas. In the mid and lower cervical spine, you do not. And this is a technique Dr. Sriram was telling me about, talking about protocols, so I threw it in over there. It's very simple. You do thin axial images. Helical CT is very simple, spiral CT nowadays. So you do 0.6 to 1 millimeters and you reconstruct into thinner axial, sagittal and coronal planes on soft tissue and bone windows. And you can see that this is a lateral spine X-ray which I cleared, but on the CT scan you can see a little subtle fracture involving the lamina of, I think this was C3 if I'm not mistaken. So why CT? Because if you look at radiography alone, the pool sensitivity for detection of abnormalities with radiography for cervical spine trauma is only about 52%, whereas CT is 98%. And it is faster and there are far fewer technical failures. In our own experience, if you look at a lateral X-ray very, very carefully, and this is a paper that we wrote in 2010 in AJR, Cicero Torres, who is one of the pediatric radiologists from Yale University now, did this work with us. And the sensitivity of a lateral spine X-ray alone, without the AP odontoid or other modalities, was 73%. So it wasn't that bad. It wasn't great, but it wasn't really bad. So make sure when you do a radiograph, look at everything on the radiograph in a stepwise fashion. Have a checklist for that. MR is becoming more important and is becoming a good complement to CT. The problem with MR is, of course, that it is difficult to do in trauma patients and takes time, but you can see the soft tissue contents, the cord and the ligaments much, much better than CT. So whenever you suspect cord injury with neurological deficit, or if you think of ligamentous injury, always do MR. And this is the technique that we use. So we do a sagittal T1. Very important that you do a sagittal T2 facet, because otherwise you will completely miss ligamentous injury. Sometimes you even need to do stir because you want to look at bone marrow edema, so that is better seen on stir. If you get a good view of the cord on the sagittal T2 facet, then there's no need to do a sagittal T2 alone. And then we do a 3D axial T2. Sometimes we'll do a gradient echo when you suspect cord injury and you want to look for hemorrhagic contusion, because that is a very bad prognostic factor. You can do MR angiography without any injection of contrast. Now you may miss subtle fractures, but it doesn't matter because the treatment doesn't change too much, but if there's any edema or displacement or subluxation, you will definitely pick it up. Now when you look for craniocervical ligaments, there are a lot of protocols coming up on using proton density images, coronal T2 facet images. We don't use them except when we want to problem solve. This is not part of our routine, but these are optional sequences that we use for the craniocervical ligaments. Let's quickly go through some anatomy. And if you see, this is from Americis, from statdx.com. You can see the ligaments very beautifully. And Make sure that whatever you do, whether you do plain X-rays, you do CT or MR, you measure the atlanto-odontoid distance very well. And it has to be within 3 to 5 millimeters. 5 millimeters in children, 3 millimeters in adults. Now look at all these ligaments. This is the tectorial ligament. Look at this space for any abnormal fluid or hemorrhage. Look at any retroclavial hematoma and other relationships, very importantly in the craniovertebral region. Now why do you want to focus on the atlanto-odontoid region like that? Because look at the anatomy of it. This is an axial CT scan where 1/3 is bone, 1/3 is CSF, and 1/3 is cord or neural tissue. And if the odontoid displaces back, then you will compress the cord and cause significant neurological deficit. This is the transverse ligament, and we'll go through it again, which is attaching to the sides of the C1 over here. And you can get sometimes an avulsion fracture from the transverse ligament being pulled out. This is just to show you some other ligaments. So these are coronal views. This is a cruciate ligament, which is difficult to see, but you often will see the alar ligament very well on the coronal view, and you can see it over here. And this is a transverse ligament again on the axial view, and you can see that this particular patient had a lot of ligamentous injury posteriorly along C1, C2. These are T2 facet images. So let's do a quick review of the ligaments, and let me see if you guys remember what I told you. What is number 1? Tectorial ligament, right? Number 2, apical ligament. And you can see number 3 is the atlanto-occipital ligament, and number 4 is the anterior longital ligament. So this is with just a CT spine reconstructed view, and even with CT spine in the upper cervical spine, you have very good visibility of soft tissues. Note that this is the odontoid, which is not completely ossified, so don't mistake that for a retroclavial or a retro-odontoid hematoma. This is just a normal variation. And if somebody wants to read more about these things, you can go to Radiographics, and there's a very good article in Radiographics 2003 on that. And it's very important that you look at this region and very carefully. For example, if you look at this axial CT scan, this was a 5-year-old who came from a motor vehicle accident. There were twins. This is one of the twins who survived. I'll show you the other twin later on, which was unfortunate actually. Both had atlanto-occipital injuries. One survived, had a very mild injury. The other one had a very unfortunate severe injury and died. So this is a small retroclavial hematoma. Don't miss that. You can see the retroclavial hematoma displacing the tectorial ligament over here on the sagittal CT. And if you do an MR, you can see the hematoma again on axial T1. And you can see it over here again on the sag T2 facet. And you can see that the apical ligament is torn. You don't see it very well. So though this is subtle, this is a very important finding. If you don't manage it very well, it could lead to chronic instability in this area. So always pay attention to the retroclavial soft tissue. So that was a little bit about anatomy and the ligaments. Let's talk about appropriateness. Who needs to be imaged? It had come to a point in the late 90s and early part of the 2003, 2002, where so much cervical spine CT X-rays was being done. And if you really look at the number of cervical spine X-rays, for example, we did an audit, and out of 100 X-rays that we do, we find abnormalities in only 3 out of them. So I joke with my residents that, you close your eyes in cervical spine trauma and you say normal, you'll be correct 97% of the time. But you don't want to miss those 3%, so you cannot do that. You need to look at it carefully. So because of the cost control that is undergoing in North America for healthcare, it's ballooning so much, there's a lot of appropriateness criteria. So this is from the USA, the Nexus study, and this is from the Canadian C-spine rule. I obviously like the Canadian C-spine rule because it carries much more clinical interaction over here. So if you have anybody who's a high risk, like more than 65 years, a dangerous mechanism like a high velocity motor vehicle accident, or any paresthesia in the extremities, you go for radiography and further imaging. If you have any of this low risk criteria where then you can actively rotate the neck, you don't have pain, there is no distracting fracture, then you don't need any more radiography. And this has really stood the test of time, and is a very good sort of way to assess for appropriateness of cervical spine imaging. Make sure, I want to again stress this, when you look at the cervical spine radiograph, CT or MR, have a checklist, it always helps. Go through the alignment all the lines that I showed you. Go to the bones, look for any small fracture fragments, look at the cartilage and the soft tissues, and you will pick up most of the abnormalities. It's very straightforward if you give attention to everything as in a checklist fashion. So let's come to some mechanisms of trauma and show you some examples. So there are some very simple ways to classify and there are some difficult ways to classify. I've made it very simple over here. Just think of hyperflexion and rotation. Hyperextension with or without rotation is a mechanism of trauma. Then compression when you have axial loading or a lateral flexion sort of injury. And then sometimes other forms of mechanism like penetrating injury and other things. So one thing that happens is we use a lot of plain radiography and CT scan for trauma. When you have things like flexion sprain or hyperextension sprain, which causes only soft tissue injury, we don't often pick it up on the CT or on the radiography, or if you do an MR, which you do several weeks later, or if you don't do facet images. And you can miss those findings, and then of course that's a lawyer's delight and a radiologist's plight. So hyperflexion injuries, the most common injuries that occur to the spine are hyperflexion injuries, and there's a variety of them that occurs, and we'll go through some of these. Hyperflexion sprains I told you about is purely ligamentous. Anterior wedge compression fractures, clay shoveless fracture. This is a hyperflexion injury, but it's also rotation of the trunk in relation to the neck, and often occurs when you're shoveling snow, which has happened very often in winter in Toronto, and you could sort of get a fracture of the C6 or the C7 spinous process. It's an avulsion injury. A flexion teardrop injury is a very severe injury. I'll show you examples of those. So this is one of the radiographs that I told you in the beginning. I had cleared this X-ray of somebody who knew one of my colleagues very well, and I missed this compression fracture. And what happens is when you're younger, at 7, 8 years old, ossification is not complete, and we see this as a normal variant very often. But in this particular child, who was actually 11 years old, so has complete ossification, you can see that there was bone marrow edema in this one, and this was a wedge fracture, compression fracture. In fact, a CT scan done in this patient was normal. It didn't show any end plate fracture. And the T2 facet images, which I'm not showing you over here because there are artifacts on it, showed the bone marrow edema much better. So cervical wedge compression fracture is a form of flexion injury. Typically occurs in the mid to lower cervical spine. This is another patient where this was way low down in the C7 area. You can compare this height to this height. And you can see the increased sclerosis along the superior vertebral end plate due to the end plate fracture. So alone by itself, it is a very stable injury, but if it is involved with ligamentous injuries, then it may become unstable. So this is a classic, this particular lateral X-ray is a classic hyperflexion injury. It shows all the findings of a hyperflexion injury. Focal kyphosis, a little bit of anterior listhesis, posterior disc space widening, increased distance between these interspinous processes, and even the subluxated facets. So all components of a hyperflexion injury. This is another classic hyperflexion or flexion injury, and that is the flexion teardrop. You can see this little fracture over here. Whenever you see that on a lateral X-ray in trauma, it's a very, very serious injury. And you can also see the increased playing of the distance between the posterior spinous processes. So it is a very devastating high energy injury. It disrupts a lot of ligaments. It's very unstable, and neurological injury is common. And when neurological injury occurs, it's usually the anterior cord syndrome. It's a specific syndrome where there's loss of pain and temperature and light touch below the level of injury, with preservation of vibration and proprioception. And this is another flexion teardrop over here, which you can see very well. There are no other components over here, but this alone itself tells you that this is a flexion teardrop, a severe injury. This is the other X-ray which I had missed, and this was actually in one of the interventional radiologists whom I used to know. And this is another person's X-ray, but his was very subtle. It was just cutting this off, but you could still see the closed shoveless fractures. So this guy, he meets me in meetings at the RSNA every year, and every time he sees me, he points a finger at me. And I say, of course I remember. He's been doing this for the last 10 years now. And I still get the blame. So, But what do? Sometimes you miss. You wish well for your friends. You don't want to pick up an abnormality, and that's why you have a bias of calling it normal. But look at every corner of the film. These things are very easy to pick up, and nobody should miss those. So I stand to blame over here. Other types of bilateral locked facets. This is also a severe flexion injury. If you have more than 50% of translation of one vertebral body anteriorly over the other, more often than not, or almost always, you'll have subluxated and locked facets. And you can see this facet is way anterior to this facet, and it won't resolve by itself, it won't reduce by itself. Sometimes you just have one facet which is dislocated, and you can see that it looks a little odd over here, and you can suspect that you'll do a CT and you'll pick it up very easily, that only one facet is locked, the other one is still in position. On an AP, you can make that out by the different alignments of the spinous processes. So this is like a unilateral locked facet, and this is called the reverse hamburger sign. If you see, this is the normal appearance of the facet where the hamburger buns. This is from learningradiology.com. This is from the internet, and this is an original case from our hospital. This is a normal finding, and this is the reversed hamburger where the buns seem to face, the convex portion of the bun faces away from each other. So that is just one way of remembering what a locked facet looks like on an axial view. Of course, when you have bilateral locked facets, you can have very severe ligamentous injury, as you can see in this particular MR, Sagittal CT MR. You can see the disc disease, and you can see that the cord is also showing abnormal signal due to severe compression. So bilateral locked facets is a very, very severe injury, very similar to the flexion teardrop. It's a high energy injury with severe ligamentous disruption, disc annulus disruption, cord damage. And this is stable because of the locked facet, but once you reduce it, it becomes unstable and requires instrumentation to be fixed. So that was a little bit of flexion injuries. We come to hyperextension injuries. So these are compressive forces on the posterior elements. So it's fractures of C1 or C2 posterior elements are classic hyperextension injuries. Then you have an avulsion fracture called the extension teardrop, which is avulsion of the longus collar attachment at C2 usually, or at the skull base, and that is a classic extension teardrop avulsion fracture. Now, with hyperextension, usually the interlaminar line, the spinal laminar line is intact, the interspinous distance is intact, and the distraction is more anterior. So Hangman's fracture is a classic hyperextension injury where you have bilateral C2 lateral mass fractures, and this fracture usually runs posterior superior to anterior inferior. This may involve the transverse foramen, where it could involve the vertebral artery and cause damage to the vertebral artery. There are three types described. One, where there is no displacement of the fracture fragments. Two, when there is some anterolesthesis and the disc is involved. And type 3 is when you also have facet disruption. So this is the classic Hangman's fracture. You can see the fracture running through the lamina of C2. And these are the different types where there's a fracture to the lamina. It is sparing the vertebral artery foramen, but there is no separation of the fractured end. So this is type 1, a fairly stable injury. There's a little bit of separation and anterolesthesis. This is type 2. There is not only separation in this type 3, but also subluxation of the facets that you can see over here. There's a small fracture from the facet joint itself. So this was type 3, a more severe form of Hangman's fracture. In this particular injury, when you have hyperextension dislocation, there's another mechanism of injury where you have variable ligamentous disruption. Particularly in older children, this can be very devastating. And this can cause a central cord syndrome where the arm weakness is much more than the leg weakness. So remember, the flexion injury is anterior cord syndrome, whereas the hyperextension injury in older people with degenerative disc disease is central cord syndrome. I remember about 20 years ago, the Bombay-Pune highway, which is a road which is frequently traveled, had a lot of potholes. And the state transport buses that used to go over those potholes, there used to be old people who used to travel in there. And in one season of, after the monsoon, in 3 months, we had 7 or 8 cases of hyperextension cord injury because of the way the head was sort of going to and fro in these old people with degenerative disc disease. So remember that sort of injury that can occur to the cervical spine. Often the MR is much more suggestive of the ligamentous injury. You can see how the disc is distracted. If you're not paying attention, you may miss that. There is also ligamentous injury between the spinous process, almost like a chance fracture going through the cervical spine. This is again the classic hyperextension dislocation where the cord damage occurs because of pre-existing degenerative disc disease and canal stenosis. Then we come to this extension teardrop, which is another classic extension injury, and this is a much less severe injury compared to the flexion teardrop. And this usually occurs higher up at C2 or C3, and you can see that this fragment is taller, more than wide. In the flexion teardrop, which occurs at the lower cervical spine, the fragment is wider, more than taller. So that's one way of differentiating it. Just to tell you, this flexion teardrop, the fragment is large. Extension teardrop, the fragment is small. Over here, the fanning, you can see the increased interspinous disc space. Over here, in extension teardrop, it occurs more anteriorly. You can see the increased disc space over here. Displacement of the vertebral body may or may not occur with flexion teardrop. If it occurs, it gets displaced posteriorly into the canal. Usually the extension teardrop is a very stable fracture and you don't have any displacement. We then come to the C1 fracture. This is the first fracture of the C1, which is due to axial loading usually. It involves the anterior and the posterior arches. You could have transverse ligamentous injury, and you may not usually have cord injury. So this is interesting that you have a severe fracture of C1, but in most instances you don't have cord injury. So Jefferson fractures are rare before teen years. They usually occur only in adults, and axial loading mechanism is the way they get ruptured. Now, if you have a transverse ligament rupture with a Jefferson fracture, then it becomes unstable. So this is a Jefferson fracture, and you can see on the odontoid view, the lateral mass of C1 is translocated more laterally compared to the C2 lateral mass. So that's one way of detecting a Jefferson fracture. So we come to some specific scenarios. Let's talk about pediatric patients. Now, compared to the adults, where most of the injury occurs in the mid to lower cervical spine, in children, the fulcrum of injury is at the craniovertebral region. So 90 to 95% of injuries before 8 years occur at C1 to C3 or the occipital, cranio-occipital region. Now there are many variants. For example, there's increased space between the anterior arch of atlas and the odontoid. So up to 5 millimeters is supposed to be normal compared to 3 millimeters in adults. Often there's incomplete ossification and these vertebrae look as if they are wedged anteriorly. That's a normal finding. In the C2, C3 subluxation, I'll show you in the next slide, is often a normal finding. It's a pseudo-subluxation. The prevertebral soft tissues are often prominent and they're often normal. So let's look at this. This is a C2, C3 pseudo-subluxation. It doesn't mean anything. If you look at the spinal laminar line, that is well aligned. So if that is intact, we are okay if the child is young, 3, 4, 5 years old. So you have to know the development of the C1 and C2 to be familiar with the normal variants in the cervical spine in young children. So C1 has 3 primary ossification centers, anterior arch and 2 neural arches, and these join at 3 years. So this is the neurocentral synchondrosis, which fuses by 7 years, and this fuses by 3 years posteriorly. If they don't fuse, they look like fractures. Don't mistake them for fractures. Sorry. The C2 has 4 primary ossification centers. It's a coronal CT scan. So one for each neural arch, one for the odontoid, and one for the body. Now remember, in children, because the odontoid is not ossified and the open mouth odontoid view is not necessary, and Swiss-Chuk described this way early in the 80s. Also remember that in children, prevertebral soft tissue can often be normal. This is a lateral X-ray of the same child on the CT scan where the prevertebral soft tissue looked abnormal, but this child was crying, and these soft tissues are lax and they can distend. CT scan done within 20 minutes of this X-ray showed normal prevertebral soft tissues. See the unossified tip of the odontoid, unossified anterior arch of atlas, and see the ligaments are beautifully seen. No retroclavial hematoma or soft tissue. The other finding that occurs in pediatric patients is that OC1 joints are very shallow. You can see how straight they are over here. In 8 years old, it becomes a little more deep, and this is a normal OC1 joint. So there's more stability here compared to here. And this is one of the reasons why children have much more atlanto-occipital dissociation compared to adults. These are the variations I told you. This is the neural arch and anterior body synchondrosis for C2. Sometimes the tip of the odontoid doesn't fuse and that it remains behind a cleft like this, which is also a normal variation. Sometimes the anterior arch of C2 never develops and then the neural arches grow over, and then this is a normal variation. Don't mistake that for a fracture. Now in children particularly, it's very important to look at these relationships, and these are very critical. The Bayesian axon distance and the Bayesian lens interval. These should not be more than 12 millimeters. So this is a normal adult where you can see the Bayesian to dense tip, which is 12 millimeters. Mind you that sometimes in children this is not ossified and the distance may increase. But in my own experience, I've audited some of this. Even when the tip of the odontoid is not ossified, the 12 millimeters works fairly well. So you can have dense fractures, and there are 3 types. One which involves the superiormost portion of the dens, like over here. On this MR you can see that. These are the most common ones which involve the base of the dens, and then you can have type 3 which goes through the base or the body. So there are 3 types of dense fractures. There are specific injuries that occur in children, and this one is very specific for children under age 8. It takes 7 or 8 years before the synchondrosis between the tip of the odontoid and the body fuses completely. So if you get an injury before that, you can get an odontoid synchondrotic slip where you can see the anterior margins don't match. So this is a specific injury in the pediatric age group. Usually you don't have to do much, just put them in a neck collar for a long time and make sure they don't get involved in high energy or contact sports, and they do very well over time. I want to briefly talk about C1, C2 or rotatory subluxation. There's a lot of confusion on this. We still don't know whether it occurs due to trauma or due to some other reasons. I believe that trauma is often incidental and it's very minor over here. One thing is we do imaging for it to rule out infection or sometimes a meduloblastoma or tumors of the upper cord, which can also present with torticollis or C1, C2 subluxations. So you have all these sort of presentations. You have this Cock-Robin's position of the child because of the stuck neck over there. In the past, I remember the neurosurgeons used to tell us to do neutral and lateral flexion views on both sides in CT scan. Forever, all my life, I've done this and I thought it was rubbish because it never added any more information for management. Unfortunately, in the last 3-4 years now, the neurosurgeons have agreed to give it up most places in the world, and they don't talk about this anymore. Because the most important thing for us to do is to show that there is no erosion of the odontoid, there is no inflammation, infection, there is no posterior fossa mass or an upper cord tumor. Once you do that, you look at the relationship of the anterior arch to the odontoid. If it is not increased, this is a stable finding, and you just need to put them in a collar and then give them analgesics for the next few months and they'll be all right. We can show very nicely the relationship of C1, C2, but they don't change management. So this is an article from Radiographics. This type 1 is the most, like 90% of the times where there's no displacement of C1 in relation to odontoid. And that doesn't change management, so there's no need to really image them extensively in multiple flexion views. So we come to craniocervical or atlanto-odontoid dissociation injuries. I showed you type 1, that retroclavial hematoma in one of the twins, and I'll show you type 3, which is very severe, and very few people survive this. Most of them are brought dead upon arrival in the emergency. So the type 3 injury is an atlanto-occipital dissociation. It occurs much more commonly in children because of the inherent instability at the cranio-vertebral junction. And when we used to use only plain X-rays, it was easy to miss them because unless you did all the measurements and looked at the relationships carefully, on CT and MR it is very easy now to diagnose these. This is the other twin of the child, very unfortunate. You can see the extensive prevertebral hematoma. You can see the skull base is a little detached from the C1, and this is Atlanto-occipital dissociation. If you look at the normal Bayesian axial interval, it's much increased, it's almost 2 centimeters over here. This is what normal should look like. Even the C1, C2 facets are subluxated. And this is a CT of the same appearance where you can see the dissociation between the skull and the cervical spine. And on CT, in the same child, you can see a lot of subarachnoid hemorrhage over there. In the skull, there's severe swelling of the cerebrum, and this child did not survive. So that was a Atlanto-occipital dissociation, a very severe form of injury. Fortunately, we don't see that very often, but when we see it, those patients don't survive. This is a very interesting, specific thing that occurs in children, and that is congenital spondylolistheis. Birth by itself is very traumatic, so they do well till they are born normally, and then as the cervical spine of the head gets distracted on its way down the cervical canal, down the birth canal, they get severe subluxation of the C1 and C2. And this is the same patient. You can see this is a midline cut. If you go parasurgically, there's a break in the neural arch of C2 on both sides. This is one side and that's the other side. To show it better, you can see the 3Ds on them and see the congenital spondylolistheis. Some people have very nicely called this Atlas shrug, where when you have a congenital spondylolistheis, as you come out, you no longer can hold the head very well and it gets sort of subluxated. So the atlas cannot hold on to the skull very well anymore. It gets shrugged anteriorly in relation to C2. I didn't show a lot of cord injury over here, but I just want to put this up, and this is more important for the trainees and for the technologists, that when you suspect cord injury, make sure you do a gradient echo T2 to look for hemorrhage. This is a regular T2 in the same child that I showed you with the atlas shrugged, and you can see hemorrhage over here very mildly, but if you do a gradient echo T2, you'll see the hemorrhage much better. And when you see hemorrhage in a cord contusion, that has a grave prognosis. This means the sensory and motor deficit may not resolve, and they'll be left behind with permanent deficits. A very brief word about occipital condylar fractures. I'm still okay on time, I think. These are frequently missed on standard radiographs, and these occur due to lateral flexion injuries. These demonstrate, so there are different types. Type 1 is the simple ones, non-displaced. Type 2, they are more extensive, and type 3 are unstable, where there's a displaced bone fragment into the spinal canal causing neurologic injury. So just to show you these different types, you can see this is a very severe injury of the occipital condyle on one side. So that was occipital condyle injuries. Remember, when you see occipital condyle injuries, look at the vertebral artery carefully and try to evaluate for vertebral artery injury in the setting of trauma. Now there are 2 or 3 unique situations that I want to talk about. One is the elderly patient, and I'll discuss this a little bit, that when you have an elderly patient, as we grow old, we get this disease, our spines get tighter and we get disc protrusions, and they also have osteopenia, so they tend to fracture easily. And even low energy mechanisms like the one I described, like traveling in a bus on a pothole rows with significant hyperextensions, can cause injury. So have a higher threshold for imaging those patients and for diagnosing the abnormalities. This is the one that I showed you with the hyperextension injury and the cord compression in an elderly patient with secondary spinal canal stenosis from degenerative disease. And think of blunt cerebrovascular injuries, particularly when you have base of skull fractures or you have occipital condyle fractures. Look for evaluating the vertebral artery at the C1, C2 area, or look for evaluating the carotid canal in the base of the skull. And CT angiographic criteria for picking up these abnormalities have been well described in literature. Vessel irregularity, wall thickening due to neural hematoma, a caliber change, an intimal flap, interluminal thrombus, pseudoaneurysm, macular extravasation. All this can easily be done with a CT angiography. So this is one example that Dr. Bharata, one of the interventional neurologists from St. Mike's Hospital, gave to me. This was a fracture through the C2 getting into the vertebral foramen, causing a vertebral venous fistula. You don't see this very well over here, but there was a very big flow from the vertebral artery into the venous plexus which surrounds the C1, C2 area. So this is the right normal vertebral artery. You can see no sort of AV fistula, But here you can see early venous drainage from this left vertebral artery injection. So this was actually embolized and they sacrificed the left vertebral artery and the patient did well. We often get these questions about doing flexion extension views and when should we do them. We should do them only when there are predisposing conditions for them. For example, if you see a patient who has no predisposing factor like Downs or rheumatoid arthritis or other diseases of the craniovertebral region, then your yield will be very, very low and there's no reason to do a flexion extension view. But if you have any pre-existing condition like this child with Down syndrome, you can see this looks normal, but on flexion there's severe subluxation of C1 and C2. That's the time when you should do it. And how do you do it? Never do it on an unconscious patient. Always do it voluntarily. And in fact, I made the mistake one time, a few years earlier actually, when I was experienced with this, where the neurosurgeon convinced me that I could do it and it would be safe. And we did it. This was in sick kids. It was an obtunded patient and their blood pressure shot down, their heart rate went low, and the patient had deficits in the upper arm for a few days before they recovered. So I was being aggressive, but I learned my lesson from that. The third thing that I want to discuss is clearing the spine in obtunded patients. There's a lot of literature now that when you have an obtunded patient, you cannot clear the cervical spine clinically. So you do radiographs, but you know that you'll miss fractures and ligamentous injury. Now, should you do a CT scan or should you do an MR? There's controversy on that. Till recently, till about 2 years ago, people were saying MR is the way to go because you can see the cord, you can see the ligaments. Now there's more and more literature coming out that if you have a normal CT, very unlikely that you'll have an abnormal MR. So, CT would be good enough to clear it. I don't think that controversy has still come to an end, so do what is best for you in your institution. If you have an MR, use it, and we use MR more often for clearing it. And you can see this is the patient that I showed you where, on the first slide, where I cleared the cervical spine. But if I had looked back very hard enough, I should have seen this displacement of soft tissue and picked up this ligamentous injury. And you can see on the MR T2 facet, there was injury at the apical ligament over here. There was interspinous ligamentous injury, and you can see the dura got stripped off the posterior arch of C1 with this flexion injury. So it was like a flexion sprain injury. Just quickly, one more minute on stability. We are very used to this three-column stability system that works very well in the thoracic and the thoracolumbar region. There is new literature now out and a new thinking of how to think of stability in the spine, and I just wanted to introduce that to you. And that is known as a subaxial injury classification, where you use not only the morphology of the vertebrae, but also the disc and ligamentous complex, but also the neurological status in scoring for instability. It's a little complex, but it is something which a lot of trauma people who do this regularly put it up on their viewing boards, and they can very easily within minutes come to this in conjunction with their clinical colleagues, of course. So a score of less than 4 is no surgery because considered to be stable, and a score of more than 4 usually goes on to surgery for fixing the spine. So a few pearls. Remember that when you do plain radiographs, a high chance of technical failure, so never settle for suboptimal films, particularly make sure you've seen the C7, T1 region. Remember that subtle findings are often very important, often at the craniovertebral region. I showed you the subtle retroclavial hematoma. If you have normal plain films and persistent pain, like I had in one of my friends where I missed a Cray-Chauvel's fracture, remember that you need to, if there's clinically persistent pain, image more, do a CT scan, do an MR. It is worth it because you see abnormalities. So at least in our institution, we have the privilege and we have the capability of taking a second opinion very fast. We are about 27 pediatric radiologists and neuroradiologists, so it's easy for us to do that. When you have pre-existing conditions, then you think that the chances of cord injury or spine injury are much more. So if you have ankylosing spondylitis, you have degenerative disease in somebody who's more than 65 years old, Down syndrome, rheumatoid arthritis involved in the C1, C2 region, make sure that you have a low threshold for doing advanced imaging. And look for situations which will make the plain films uninterpretable. For example, morbid obesity where you can't see the bones much. or very, very severe degenerative disease, very difficult to pick up fractures or subluxations. So that was it, and I'm looking forward to seeing more of Kuwait. Thank you for having us over here, and greetings again from Toronto, from all of us. Thank you.